Listen, in this video, I'm going to go over the GI disorders that are going to be on exam 3. Now, you do have some eating disorders. There's one question. In your recorded tutorings, I have a video with Mrs. Greenbaum teaching you all about what you need to know for eating disorders. And so you can study for your mental health proctor at the same time. Okay. So I'm going to start with GI diagnostic tests that you need to know about. So the first one is the fecal occult blood test and also gathering stool samples. So we gather stool samples to check for occult blood, which means hidden blood, like you can't see it, right? It's not like black tarry stools. You would still test those for blood, but we might test stool for ova and parasites. And if we think somebody has C. diff, like if they're on like a tube feeding and they start getting diarrhea, or they're on antibiotics, we might start to think, oh no, they have C. diff. So we would have to send a stool sample. All right. So you need 3 samples to test for occult blood. Okay. So you smear the stool on a card, and you're going to instruct the client to avoid vitamin C rich foods, red meat, poultry, and fish for 3 days. And that's because those foods can make false positives. So you want to make sure there's none of that in their stool when you get the samples, okay? For ova and parasite testing, you give the cup to the patient and keep it refrigerated. Not in the same refrigerator that you would keep your lunch, okay? But in the refrigerator that is identified to hold specimens. All right, with endoscopy, I'm going to talk about a couple different tests and tell you some important things about them. So the first test I'm going to talk about is a colonoscopy. And this test is done usually on people over 50 years old to detect polyps and colon cancer. And this scope enters via the anus. And the reason I'm telling you that is because you don't have to worry about a gag reflex after this test, okay? You will have to worry about it on other tests, but not this one. Anesthesia, all these endoscopies are done under moderate anesthesia. So what that is, the nurse will give fentanyl and usually, not diazepam, Versed. Midazolam is what you know it as. So when I worked in cath lab, that's how I used to medicate people before doing the cath. So the positioning is going to be left side, knees to chest. The patient is going to need a bowel prep, and they'll start that 1 to 2 days beforehand, and it's not fun, let me tell you. You have to drink a lot of fluid, and the bowel prep has a laxative, and you're going to be on the toilet all day. So no red, orange, or purple fluids. That's because the provider doesn't want to see that color in your bowel. Now you have to clear your bowel out with all the stools so the provider can see when they're doing the colonoscopy. Now, with older adults, you have to worry about them having fluid and electrolyte imbalances because they're going to have diarrhea from the test and metabolic acidosis. So that would be very concerning. Post procedure with this, when I worked in a place that did this, patients have massive amounts of flatulence. I mean, it's just expected. They're going to have lots of flatulence. Okay, the EGD is also called like upper endoscopy. It's a esophagogastroduodenoscopy. All right, and it can be done to dilate esophageal strictures, to diagnose gastric lesions, and the scope goes through the mouth. And the mouth is anesthetized. Okay, so the patient's going to be side lying, head to bed up. They need to be NPO 8 hours before. But after, you need to check the gag reflex because they've had moderate sedation, but also they like numb the back of the throat when they're doing it, okay? And you don't want the patient to aspirate. That's why you check the gag reflex. All right, the ERCP stands for endoscopic retrograde cholangiopancreatography. So this is a side-facing scope, and that's not really what's important, but this scope enters in through the mouth into the duodenum to view the biliary tree. Okay, it does use contrast medium, so all those nursing implications apply. So check the BUN and creatinine before you send somebody for one of these, and hold metformin. They're a moderate sedation, but you will have to check the gag reflex after. A sigmoidoscopy, this can be done bedside. No, there's no prep, there's no anesthesia. It's not a big deal. A capsule endoscopy, no prep. No anesthesia, so you don't really need to worry about that. So your complications of endoscopy, anytime you put a scope in somebody, is hemorrhage, perforation, bowel perforation, so fever, tenderness, distension, and aspiration. So that's why you check the gag reflex. Okay, so listen to their lung sounds, check their gag reflex. Now a GI series. A barium enema can be done, but it has to be done before an upper GI, which is a barium swallow with follow through. An upper GI, they drink the barium, and then the provider takes a bunch of images. So post procedure, post GI series, they're going to need the laxative to get that barium out. Barium is like a white color, so their stools are going to be white for 3 days. You need to increase fluids. And they need to make sure they're passing the barium. All right, for non-inflammatory GI disorders, first I'm going to go over the proper sequence that you're going to need to know that you do assessment in for abdominal assessment. So first you want to inspect, then auscultate, then percuss, then do palpation, even though we don't like really percuss, okay? But that's the proper order. And I just remember I am perfect pal. That's how I remember the proper order. And the reason you auscultate before you touch the abdomen is that you don't want to inadvertently make the bowel start moving around because you're going to get false bowel sounds, okay? That's why. All right, I'm going to talk about hernias for a little bit. There's hernias, you can have hernias in a lot of different places, like incisional hernias, umbilicus. I've seen hot spots on ATI where they want you to differentiate between an inguinal and a femoral. Remember, the femoral is lower, okay? If you have somebody with a hernia and you can push it back in, we call that reducible. And we don't really worry about reducible hernias, okay? We worry when hernias cannot be put back into place. We call that irreducible, or incarcerated. Your patient will need surgical evaluation because this could lead to obstruction. So the provider is going to want to operate sooner versus later. Now, another type of hernia that is dangerous is a strangulated hernia, and this is when blood gets cut off to the bowel. All right, so it's going to become necrotic, and they could also have intestinal obstruction and perforations. So your findings, if somebody does have an intestinal obstruction, or due to either strangulated or incarcerated hernia, your patient will be tachycardic. They'll have abdominal distension. Their vomit is going to smell like fecal matter, and they'll have a fever. Okay, intestinal obstruction. There's two types. There's mechanical obstruction, which is going to need surgery, and then there's non-mechanical obstruction. An example of a non-mechanical obstruction would be a paralytic ileus that people have like after surgery. So you wouldn't hear any bowel sounds. And then you would encourage ambulation to promote flatus. Flatus is good. Flatus means that peristalsis is going on, okay? You know somebody has peristalsis if they have flatus or if they have a BM. Bowel sounds are not as reliable about peristalsis, so it's always better to know if somebody's passing flatus. All right, there's a lot of reasons people can have intestinal obstruction. So they could have had surgery years ago and now they have adhesion. So they're going to need an exploratory laparotomy to lyse those adhesions so that they don't get an obstruction or to alleviate an obstruction. People with cancer can obstruct their bowels. People with either strangulated or incarcerated hernias. People with intussusception. And you'll learn about this more in pediatrics, but this is when the bowel telescopes on itself. Volvulus means the bowel turns on itself. Okay, now why we worry so much about obstruction is because it can result in death if you don't catch it early, okay? So We're worried that the bowel is going to perforate, or in other words, rupture, cause peritonitis, and then death. Okay? So what you're going to hear on auscultation if somebody has an intestinal obstruction is high-pitched tinkling sounds above the obstruction in one quadrant and hypoactive bowel sounds in another quadrant. In a hypoactive bowel sound, you do not hear that sound for 30 seconds. That's the definition. Now, with peritonitis, I've gone over this a lot, but it's important because your patient can die from it. They're going to have a rigid, board-like abdomen, a high white count, tenderness with guarding, abdominal distension, a fever, okay? So you fix it or the patient's going to go into shock and then die. All right, now with gastritis, gastritis is inflammation of the stomach lining. It can be non-erosive or erosive, or it can be acute or chronic. I'm just going to give you the skinny on what you need to know. So it can be caused by H. pylori. It can be caused by taking too many NSAIDs, which is kind of classic. It can be caused by drinking too much, smoking, and caffeine. So all the fun stuff, right? Your patient's signs and symptoms, they will have black, tarry stools, much like duodenal ulcers. Okay? The heartburn, they complain of heartburn, abdominal pain, anorexia, nausea, and bloating. So your complication, the thing you're worried about with patients that have gastritis is that they're going to hemorrhage. So they'll have bleeding, GI bleeding. And so to stop this, obviously stop taking all the NSAIDs, drinking, etc. Constipation teaching. So if your patient becomes constipated, you're going to encourage increased activity or exercise, increased fluids. They need to drink more water, eat high fiber food or to add bulk to the diet, bulk providing food, and go try to defecate at the same time every day. They can also drink like warm prune juice to try to get it going, or, coffee works too, okay? So medications, this is the order that you would, do medications in. First, you would start with your bulk forming first. You always want to try to take care of constipation without medications, but if you can't, start with the bulk performing first, then stool softeners, then stimulates, then enemas as a last resort. All right, now I'm going to go into some other problems. So I'm going to talk about GERD first. So GERD is the most common upper GI problem, and it stands for gastroesophageal reflux disease. Essentially what happens is something weakens the lower esophageal sphincter, which is right here, right? And so now the gastric acid can come back up the esophagus, okay? Normally it's closed, okay? So it's relaxed and closed tight. So a hiatal hernia can do this, which is a hernia outpoaching up here around the esophagus, and that's treated the same way GERD is treated, okay? So obesity, pregnancy, and smoking can also be risk factors. Anybody with like a really big belly, it's going to cause pressure on the lower esophageal sphincter. And so what you worry about with somebody with GERD is they may end up getting what's called Barrett's esophagus, which is can be precancerous. So they're going to need an EGD, upper endoscopy, all right? And signs and symptoms, heartburn, especially when they go to bed, shortness of breath, cough, chest pain. Patients that present with this, sometimes you can think they're having a heart attack. That's how bad their pain is. Diagnosis I talked about with endoscopy. So the medications include antacids, which can be taken PRN, H2 blockers. The PPIs have to be taken daily, and the prokinetic drug therapy, that's your Reglan. So those can be the meds that they need. So you're going to encourage lifestyle changes. They need to lose weight. They need to have a healthy BMI, right? Less than 30. They need to stop smoking. They need to elevate the head when sleeping. And I think I have that down here. So, and all these disorders, right? Gastritis, GERD, when I talk about peptic ulcer disease, you want the patient to stop eating like spicy foods, Stop taking NSAIDs. Stop drinking alcohol. Stop drinking coffee on an empty stomach. Stop, anything that's like irritating to the gastric mucosa, you want to stop. All right, so this is what you would do. The teaching, you would tell patients that had GERD to alleviate the symptoms, they need to be NPO for at least 2 hours before they go to bed. It can be more hours, but at least 2 hours. They need to raise the head of bed 6 to 8 inches. So they need to get like blocks to put under their headboard, in the bottom, so it raises the bed up a little bit if they can't afford like a medical bed. Eat a low-fat diet. Do not wear tight clothes. No smoking, no alcohol, no caffeine, no fun. No, just kidding. So peptic ulcer disease is either acute or chronic. They can occur in the esophagus, the gastric area, or the small intestine, which is duodenal. So the causes include the same thing: H. pylori, long-term use of NSAIDs, alcohol, people with gastritis, family history of ulcers, and then what you're worried about is bleeding and perforation. So that's why they need to be treated. So the signs and symptoms. Now with a gastric ulcer, they are going to have pain every time they eat. Okay, and that makes sense to me because when you eat, it goes immediately to the stomach. Whereas duodenal ulcers, food makes the patient feel better, and they get pain 3 hours after eating, and that makes more sense to me because the small bowel is lower than the stomach. All right, so they wake up. People with duodenal ulcers wake up in the middle of the night. Now, people with gastric ulcers, they may be vomiting blood or coffee ground emesis, whereas people with duodenal ulcers are going to have dark, tarry stools. So monitor for GI bleeding. I talked about fecal occult blood testing before. And basically, it's the same education. Avoid alcohol, caffeine, smoking, fried food, spicy food, sodas, and eat a low fiber diet. All right, enteral feedings. I'm going to just talk about a few things. There's like a lot of different ways, like methods that patients can have enteral feedings. It's not always nasogastric. It's not always a PEG tube. There's like a lot of different ways. Feedings may be intermittent or continuous. This is a disposable bag, and I don't think you're going to see this a lot, but yet it's still highly tested on ATI. Okay, so you're going to date and time the bag with your initials. You change this bag every 24 hours. The liquid you put in needs to be room temperature, because if it's too cold, the patient's going to have cramping, right? You're going to put it in. It can only stay in for 4 hours. In other words, you only put enough in for the next 4 hours because it could, get bacteria in it. Now, if you have pre-made feedings, this is what I see more of. It will come with like tubing and stuff, and you can hang this for 24 hours. So that's like the way to go. Now, if you're going to deliver it through a nasogastric tube, remember before you put the nasogastric to measure from the tip of the nose to the ear and then to the xiphoid process, because you're going to mark it at the xiphoid process, and that's how far you're going to put the NG tube in. X-ray is the gold standard that you use to verify the placement. Do not initiate enteral feedings until you've got the placement by a chest X-ray. Now, this is a Salem sump tube or an NG tube. It's a double lumen here. And the reason you would use this is because it prevents this tube from like causing ulcers. That's one way. This is the pigtail. Okay, you keep this above the waist. Don't effuse anything through it, and don't clamp it. And they have nice little things that you can put on so that, like vents, so that, like, because what happens is if you were doing nasogastric, like suctioning, this may fill up. All right, so you always want to check placement. On the NG tube, you can't really see it on this one, but there are markings that tell you the centimeter mark, and you would tell like the offgoing nurse it's at like 52 centimeters on the right nair is how you would do that. Make sure you're checking bowel sounds. Keep the bed up 30 degrees or more during feedings, and for at least 1 hour if you're like giving continuous feedings. All right, and all the time when if you're giving continuous feedings. All right. Check the nose for background if they are using a nasogastric tube. Some complications. So overfeeding is a complication. So what you would do is check the residuals Q4 to 6 hours, depending on what your facility says. Possibly hold for residual of greater than 100 to 200 mLs. I would definitely hold it because that's a lot to have a residual that much. That means there's something like the bowels aren't moving or something. You don't want your patient to aspirate. Diarrhea, okay? If your patient is on a tube feed and they develop diarrhea, and I feel like it's almost inevitable, like anybody on a tube feed is gonna get diarrhea, but you're like, oh shoot, right? You gotta slow it down, notify the provider because you gotta send the stool for C. diff, talk with a dietitian about maybe changing the formula, see if that's what's causing it. Hopefully it's not C. diff. Aspiration, that's why you check the tube where it's supposed to be, measuring it, and you check the x-ray results because tube displacement is usually the reason people aspirate. Keep the head of bed 30 times 1 hour after bolus feedings and all the time with people that have continuous feedings. Monitor their temp and their lung sounds for everybody that's on enteral feedings, okay? Not just people you suspect have aspirated. You should be doing that ongoing. Oh, whoops, I forgot parenteral. Okay, so TPN. Okay, I don't know if you know this, but TPN is evil. What I mean by that is TPN can wreak havoc on the body. The provider will only order TPN if the gut's not working. If the gut is working, the patient should have enteral feeding because it has a lot of benefits. It helps them promote immunity. Um, it helps prevent a lot of infection, enteral feedings, whereas TPN attracts bacteria because it's sugary, okay? So total TPN has a dextrose of greater than 10%. So like even non-diabetics will have high blood sugars on TPN. So your nursing interventions for TPN, first of all, usually TPN, you have to double check the order with 2 people and make sure what's written on the bag, you can't see it here, is what is supposed to be in there. Usually there's a time for it. Like everywhere I've worked before, it's 8 o'clock at night. That's when you change TPN. That's when you go look for another nurse to come and check your TPN with you. Okay. You're going to monitor the electrolytes daily, do a daily weight. You're going to check blood sugars every 4 to 6 hours because, like I said, because of the high sugar load, your patients can have hyperglycemia and they'll need regular insulin. Now, you can put insulin inside the TPM bag. There are some drugs you can put in it, but usually providers, you have more control if you don't put it in because you can put them on a sliding scale. All right, you never speed up or stop the TPN abruptly because your patient is going to get hypoglycemic. So if you keep 10% dextrose handy in the room, which like we can't really do that anymore, but that's what the answer is going to be. And you hang that if you come into the room and you find like your TPN is run out and the other bag isn't available, you're going to hang D10. And you change the whole bag and the tubing every 24 hours. The port you use, it has to go through a central line. The port you use is only used for TPN. You don't put meds in that line. You don't give blood through that line. It's only for TPN. So your complications include fluid overload because it's so high in sugar, it's hyperosmolar. It's going to encourage fluid from the periphery to come into the vascular system. Okay, so your patient could have fluid overload. air embolism, hyperglycemia, and infection because bacteria love sugar. All right, I'm going to talk about bariatric surgery. It's really a good thing. I used to work in a center of excellence for bariatric surgery when I worked in the PACU, and it was awesome. So the qualifications for obesity surgery include a BMI greater than 40 or a BMI greater than 35 with one morbidity, like somebody has diabetes with a BMI greater than 35. So there's two different kinds of types of GIs, bariatric surgery. There's restrictive surgery, and this is like the newer type of surgery. It's better than the malabsorption surgeries that we used to do long ago. So restrictive surgery, the goal of that is to reduce the stomach volume so the patient can't eat as much. Okay. Um, so this includes lap adjustable gastric band, lap sleeve gastrostomy, vertical banded gastroplasty. So um, there's a lot of different variations on what they can do, but basically you have to know the difference between restrictive and malabsorption. So a Roux-en-Y is a type of malabsorption surgery, and the stomach is reduced. Size and weight loss is consistent for 20 years later. The thing about it is, it's a big surgery, and the surgeon I worked with did it all laparoscopic, and it was wonderful. And patients were able to go home off all their like blood pressure meds and insulin like 2 days after they had the surgery. But the problem with it is they're always going to need iron, B12, calcium, and folate for life. They're high risk for DVT and pulmonary embolism because, first of all, they're overweight to begin with. So they're going to be high risk. So the complication that you may see after surgery that you need to look out for is an anastomach leak. So that means that the bowel is leaking. Okay, patients can die for this, so you have to recognize this early. They're going to have increasing back and shoulder pain. They're going to have tachycardia and they'll get restless. They'll have oligoria. So call the provider immediately. That's a like medical emergency. I don't know if I ever told you this before, but they do have an NG tube when they come out of surgery. If a surgeon puts in an NG tube, never manipulate it, never put it forward, never pull it back, because the provider has put it in and the provider knows exactly where their sutures are. If you try to advance that, you could pop some of the sutures and they could have a leak, so you don't want to do that. Okay, now a lot of people um, after a Roux-en-Y may develop what's called dumping syndrome. And I know ATI loves dumping syndrome. So the signs and symptoms include tachycardia, cramps, diarrhea, diaphoresis, and fatigue. So what essentially happens is the food from their small stomach now is dumping into the duodenum. Okay. So here are the interventions that prevent dumping syndrome that you're going to need to know. You withhold PO fluids during meals. They can start having fluids 60 minutes after meals. So in other words, you don't let them drink with a meal. They should drink fluids between meals, not with meals. And it's caused by eating refined sugar, so limit sweet drinks, avoid simple sugars in milk products. Like, the lactose can cause it. Eat 6 small meals a day. Eat slowly and chew well. Now, they need to lie down after meals to slow the stomach emptying. And this is different than all the other conditions we've talked about. So don't get confused on which one lies down and which are the ones that have to be, have the head of the bed elevated. You want them on a high protein, high fat, low fiber, and low carb diet. All right, stomas. I'm only going to say a couple of things about stomas because I think you had this in fundamentals, okay? So with stomas, stomatitis, it has nothing to do with stomas, but that stomatitis, this will probably show up on your proctor. They like to test about this. So you had this in Med-Surg 1. Anyways, you need to avoid spicy foods, salty foods, acidic foods, alcohol, and tobacco. So make sure they eat soft food and avoid glycerin-based mouthwash. Um, they need to rinse their mouth frequently and gently brush and floss. So they need to rinse their mouth before and after meals. And there are medications they can use. Okay, so I'm going to talk about types of, now I'm going to flip over to ostomy surgery. So the types of ostomy surgery include colostomy, ileostomy, and urostomy. Regardless of the type of surgery, a stoma is made, and a stoma should always be shiny, red, wet, or moist, protruding 3/4 inch, or flush with the skin. The shape is either round, oval, or irregular, and that is so important immediately after surgery to know, because you never want to see a dusky stoma, because it could mean it's getting necrotic. All right, this is just colostomy, different types of colostomies that you would see. And then this is the loop ostomy, so they would have this support underneath it. So with the loop, it's not an end ostomy. So this could end up being put back together. Anyways, this is double barrel, this is end. So this end is brought out, this end is brought out. Usually done for cancer and obstruction. Okay. So, an ileostomy is located in the right lower quadrant. I know ATI likes to ask about that. Koch's procedure, this is a continent ileostomy, and they don't really do it anymore because it had such a high complication rate, but yet here we are because it's still being asked. This is a red rubber cath, okay? You see how it doesn't have a balloon like a Foley or a place to blow up a balloon? Now, this is the same type of cath you would use to straight cath somebody. It's just called a straight cath, red rubber cath. So it doesn't have a balloon on it, but that's how they would use this catheter to help drain the stool out. There's also a continent urostomy. So urostomy is a urinary diversion. The ileoconduit one is the most common type. So they take a little piece of the ileum, they make a conduit and bring it out through the skin. So it's going to have mucus in it. Always will have mucus in it because it's a piece of bowel. The Indiana pouch, I took care of one of the first people in the country having one of these. This is a continent urostomy. They make it out of bowel. They make a little reservoir, the surgeons, and then there's a stoma there, and they straight cath themselves frequently throughout the day. All right, you need to know the opening of the appliance should be 1/16 to 1/8 inch larger than the stoma to prevent constriction. And report pale, dark red, purple, brown, dark or black to the surgeon, the stoma, immediately. All right, inflammatory bowel disease, and then I'll let you go. So, with inflammatory bowel disease, the first two I'm going to compare and contrast is Crohn's versus ulcerative colitis. So they're both autoimmune diseases. Crohn's affects the whole GI tract, mouth to anus, whereas ulcerative colitis only affects the large colon. They have the same risk factors like smoking, family history, and Jewish people. The signs and symptoms with Crohn's, they're going to have pain in the right lower quadrant or cramping, diarrhea, anorexia, and weight loss. Whereas with ulcerative colitis, they're going to have pain in the left lower quadrant, bloody stools, anorexia, and weight loss. The treatment for Crohn's and ulcerative colitis. So with surgery is a Band-Aid for Crohn's. It doesn't cure them. Whereas a total colectomy, somebody can have their whole colon taken out and it would cure somebody of ulcerative colitis. All right. They're both going to be on long-term steroids. These diseases are characterized by periods of exacerbation and remissions. Their diet needs to be low fiber, high protein, and fluids. So it's the same diet. And if they were having exacerbation and they were in the hospital or you were seeing them in the community, you'd want to monitor their weight, their I&O. You want to monitor the characteristics of the stools, like how many stools are they having. With ulcerative colitis, it can be they can be really bloody and mucousy. Um, you want to monitor their bowel sounds and teach ostomy care after surgery. All right, so there is no there is that you want a low fiber diet. Oh, I already talked about that. Okay. Appendicitis. This is an inflamed appendix. You want to act on it quickly because you don't want it to rupture. So patients are going to have intense pain in the umbilical area, radiating to the right lower quadrant. So here's the umbilicus. It radiates here, and this is called McBurney's point, which is near where your appendix is. Okay, so that they'll have pain there and they'll have rebound tenderness, like the provider presses on the belly here, they're going to have pain here. That's what that's called. All right, they'll have fever and increased white count. The complication is peritonitis, so you should know the signs and symptoms by now because I keep talking about it. You never want to put a heating pad on this because you could make the appendix rupture. And it's dangerous when the appendix ruptures because they're going to get peritonitis, but also for young women, they can become sterile for having their appendix rupture. If it ruptures, the pain gets better. That's not a good sign. You do not want that. All right, now I'm going to move on. So they would get an appendectomy via laparoscope. All right, diverticulosis versus diverticulitis. Diverticula or diverticulosis is characterized by these outpouchings in the large bowel, the large colon. It happens in older adults, and that makes sense to me because everything gets weak as you get older. Okay, so they have these little outpouchings. They can get diverticulitis if the outpouchings become inflamed. So they're going to have pain in the left lower quadrant. They'll have a fever. The diet will be low fiber progressing to high fiber, but they shouldn't eat nuts and seeds because you don't want it to get caught in one of these diverticuli and then cause diverticulosis. So you can only get diverticulitis if you have diverticulosis. All right, that's it. GI.